All right, we know we have a handful of folks that are in the lobby and getting some snacks, but we want to get moving so that we can stay on time. We have another incredibly meaty topic for you, and bios are in the packet that you have, but this is a star-studded group. I've told several of them today that I'm not sure in our current universe there is a more difficult environment, business and environment and otherwise, than healthcare and insurance. And the sort of mix of those is an incredibly difficult environment in terms of both the business model and finding workforce and meeting the grand mission that is really before each of these gentlemen today. So I'm thrilled they would make some time to have this conversation with us. These are major employers in our region, but provide an outsized benefit and to our greater public good, and we're thrilled you're here, and we appreciate that. And so let's get down to this. So let's start with Michael Gibbons and Sam Lynd. Both St. Bernard's and NEA Baptist do serve a large and diverse population, and we think of you as, the ones that just, fix our problems, right? We come in broken, and you fix us from a healthcare standpoint. But we did want you to take a moment to just sort of kind of give us some context. How do each of your organizations contribute not just to the physical health of this region, but also the economic health as well? Sort of paint a picture a little bit about that sort of economic impact. And you Sam, had the pleasure of sitting close to me, so you can roll, and then we'll hit Michael on the end here.
I told you I wasn't scared of you, and now you're making me pay for it, huh?
That's right.
Yeah, I think it was been mentioned a couple times today, the economic importance of healthcare and even hospitals specifically, especially in our state, right? As you mentioned, our two organizations are two of the largest employers within Craighead County and across the Northeast Arkansas region. You look in just about any community across Arkansas, their local hospital is probably in the top 3 of their largest employers, right? So major creator of jobs, and certainly a lot of downstream jobs created because of the business that we do, the supplies we buy, the care and services that are needed before and after hospital care. It's led to the success and growth of our organizations in this region, and certainly the growth of other healthcare organizations as well. In attracting employers to come to Northeast Arkansas, certainly one of the first questions that they ask, because they know their potential employees are going to ask, what's the shape of what? 2 things: schools and healthcare. And so in every scenario, from an economic development standpoint, we're certainly one of the cornerstones as an industry of economic development, especially in the state of Arkansas.
Yeah, I appreciate the context, because we don't often sort of contextualize the economic impact of that. Michael, how do you sort of see, what can you add color to that from a St. Bernard perspective?
One key thing I can share is the Arkansas Hospital Association just did an analysis across the state, and healthcare is $1.8 billion in Northeast Arkansas. Speaking of St. Bernard's is actually the 4th largest medical center in the state of Arkansas as well, behind 3 others that are in Little Rock. So you can just see the size and the impact between both of NEA Baptist and St. Bernard's within the region. St. Bernard's does have the benefit and blessing of being the largest employer in Northeast Arkansas, so we employ about 4,700 employees. And the great benefit is we do have 4 medical centers, but we also have numerous clinics across our region. So when you go, for instance, our administrator from Wynn is here, Garrett Morgan, you go to Cross County to Wynn, his hospital is also the largest employer within that community. So we're not only impacting Jonesboro, but we're impacting the 23 counties across the region that we also serve.
Yeah. Great context to sort of help us set the stage here. So I'm going to stay with both of you first, and then we'll go to Michael first this time, just to not completely pick on you. But we think about you here, and you think of Jonesboro, but there's also a collection of what we would say maybe healthcare disparities in our region, and I'm sort of curious how you think about, and your son, service initiatives to underserved communities, especially those with a variety of healthcare disparities in that region that you serve. So do you want to start, Michael?
So it's a unique year for us, and I need to make a pitch for this because it's very special to us. St. Bernard celebrates their 125th anniversary in 2025. There's not a lot of organizations that can share that. Throughout those 125 years, our focus has been on our mission and really reaching out to the communities and seeing what the need is and ensuring that we meet those needs within the communities. If you look back over the last 10 years, one great example that we share over and over again is within our region, we did not have a neonatal intensive care unit 10 years ago. And so every mom that delivered had to have their baby flown to Little Rock. And every year, about 250 moms were traveling to Little Rock to receive their care every year. That was something that we saw a need for. We created that need within our community, and now, this last year, we saw over 300 babies within our neonatal intensive care unit. Another one that really proud of, and since Representative Ladyman is here, want to kind of stress this one. There is a huge disparity within this region, especially within the counties bordering the Mississippi River, with prenatal care. OB has become a huge issue within our community, and so there was an initiative through the House and the Senate and also through our governor to move forward with what is called a Maternal Life 360 program. And so St. Bernard's was the first to apply for it. We received it this last year. We've already started seeing clients within this program. But a lot of these moms that are in Medicaid do not have transportation. So one of the things that we identified with the state in partnership with Medicaid and the Arkansas Department of Health is we actually go into the home for prenatal and postpartum visits up to 2 years after delivery. And that was through the foresight of the House and the Senate and our state government. I think that's going to be a great program that's going to make a huge difference in disparity of care within our region. It's much needed. So the focus is on infant mortality, actual postpartum mortality as well, and how can we reduce that? That's just one example.
Yeah, great example. So same thing, sort of what do you see as, what are some of those disparities we need to be mindful of, and there are particular initiatives that you see Baptist sort of stepping in the gap?
It's hard to pick one. The answer is all of them, right? I think back to 2009 when the Affordable Care Act was first coming out, we were trying to interpret what that might mean. There was an early theme of, hey, we're going to address disparities and prevalent healthcare conditions by trying to turn provider focus onto pay for performance, right? And that may mean outcomes, closing those care gaps, and focusing on those disparities. We haven't seen that evolve as quickly as we thought, but still today, if you take a map of the United States and pick a health disparity, pick a condition, whatever it may be, typically the worst color of red is going to be in our area, right, on our state. And there's a lot of reasons for that, a lot of levers to pull on that particular subject. And so the answer is all of them. All of those things need attention. But I think one of the good things that maybe the Affordable Care Act helped move forward before it stepped back was a real focus on care coordination. And communicating with patients what they need from a screening and diagnostic perspective ahead of time before we identify conditions, and then how we ensure they get the treatment they need going forward. And so that's one area that I'm really proud of, that our organizations continue to focus on over the years, continue to grow our investment there and continue to see good results, even though the reimbursement and payment incentive model for that never really came forward. We're starting to see some traction on that now, but it's been a continued focus of ours because aside from the model incentivizing is just the right thing to do for patients, and we're starting to see some good results around that work.
Between both of your organizations, ballpark, at any given time, what percent of the quantity of employees you have, what percent is open? What percent of open jobs do you have? I assume you have no open jobs, you have all the nurses you need and all the physicians you need and all the support staff you need, or how big of a gap is your workforce need versus what you have? Do you have a quick estimate of how many positions you have open?
Yeah, I'm happy to talk about it because I'm excited about it. I think we're the closest we've ever been to filling all those gaps. We have 29 open nursing positions in the hospital today. That's the best we've had in years, even prior to the pandemic. And so that's really exciting progress there due to a lot of, and we can get into this, partnerships and focus on things that even we've heard from other industries mentioned today. And then in our clinic division, we probably have a little bit more than that across various disciplines. So from percentage-wise, we're probably looking at 5% to 10%. But with a lot of focus, especially in a post-pandemic world, we're at our lowest turnover and our lowest vacancy rate in a number of years.
Encouraging. Michael, any context on the workforce needs?
Yeah, percentage-wise, we're probably very similar to Sam. I would share with you this last year, couple of years, we've had a great success with nurse recruitment. Great partnership with Arkansas State University. We actually created a whole division at St. Bernard's that is specifically on nurse recruitment. In fact, Lori Smith, our Vice President of Human Resources, is here, and she spearheads that program. We have actually seen our vacancy rate decline significantly. This last year, through growth and development in the services that we offer, we hired over 250 nurses to work at St. Bernard's, 130 of them new graduates. And they are from this region. They work and live in this region. And we're seeing nurses seek out to work at St. Bernard. So our vacancy rate in nursing's gone very down extremely. There's other opportunities, though. Where we're seeing great opportunities is there's not enough radiation technologists within the region. So if you have any children that want to go into a field, please encourage them to go into that field because it's in high demand. Pharmacy is another one. We just cannot find enough pharmacists. You used to have too many pharmacists about 10 years ago, and now it's flipped. You can't find enough pharmacists. And so we're constantly looking for pharmacists and pharmacy techs and trying to ensure that we hire them. And my CFO just commented to me, accountants is another one. A lot of people, when they think of healthcare, they don't think of things outside of nurses and physicians. Accounting is a huge opportunity in healthcare. And I'll also share with artificial intelligence and everything that's happening, the whole information technology leg of healthcare is going to open up, and there's going to be huge opportunity in that area as well.
Well, Dr. Speights, we know one of our gaps in the state is finding the right kind of physicians to really help us in a whole host of rural areas in particular. And with the College of Osteopathic Medicine, you have a unique mission to sort of train physicians that really fill those gaps in this Delta region and other parts of our state. So I'm curious, how does that focus on local needs sort of impact the way you train and prepare students for medical careers?
So it's interesting. In 2014, when we started the conversation about creating the second medical school in the state of Arkansas, the first osteopathic medical school, we got a lot of pushback. Arkansas didn't need another medical school. We're doing just fine. The data showed we weren't doing just fine. The data showed we were toward the bottom in terms of number of physicians per capita. The data showed that our health outcomes were some of the worst in the country. Thank goodness for Mississippi. As you've already heard, our maternal mortality outcomes are some of the worst in the country. Our infant mortality rate is third worst in the country. We've got significant challenges, yet we didn't need any more physicians. You couldn't grow physicians. So now today there are 4 medical schools in the state of Arkansas. Instead of graduating 150 a year, we're graduating over 500. Back in that 2014 time frame, I thought about Dr. Woodruff, who's in the audience today. During that time frame, we graduated an average of 1 or 2 internal medicine doctors per year for the state of Arkansas. 1 or 2 general internal medicine physicians for a population of 3.3 million people. No wonder he had a hard time finding partners. No wonder he had a hard time finding that next generation of internal medicine physicians that were going to come behind him. Now, we graduate over 120 a year for the state of Arkansas. And so when we talk about the word catalyst, and we talk about making change, we talk about accelerating change through a process, that is one of the things that we saw when we started this medical school. And I don't take credit for that. I've got an amazing team. Part of them are here today. We had an amazing thought leader in Dr. Barbara Ross-Lee who said, we can do better in the state of Arkansas. And so she helped plant those seeds, and we're grateful for that. One of the things that we do is we follow a whole lot of data. And what I mean by that is when you look at someone who graduates from medical school, about 50% of them will stay in that state they graduate from medical school and practice medicine. When you look at somebody who does postgraduate training, that's when they go to be a pediatrician, family doctor, internal medicine doctor, about 50% will stay in the state where they do that training. However, if they do medical school and postgraduate training in the same state, 80% of them will stay in that state to practice medicine. The other piece that we were familiar with was if we can train students in the areas you want them to practice, they're far more likely to stay there and practice medicine. So we use something called a distributed model of training. So here on the A-State campus, we have beautiful Wilson Hall, which A-State renovated, and we pay a small lease payment on. I'm teasing, it's a large lease payment, but happy to do. We're happy to do, Dr. Frey, yeah. But they're here for 2 years. This is where they get their, biochemistry, gross anatomy, a lot of the doctor-patient relationship courses. So the first 2 years of medical school is spent here. The third and fourth year of medical school, we send them out. Now, we could have kept most of them here, and we've got 2 great partner hospitals that would have kept almost all of those students here in our area to practice and to rotate. But that was not the mission of our school. The mission of the school was to meet the needs of the state of Arkansas and the workforce shortages out in the rural and underserved communities. That's where we send them. So we have our students rotate in Mena, in Wynn, in Arkadelphia, in Pocahontas, in Walnut Ridge, in places outside of Conway and Greenbrier. All over the state is where we send them. And you know what we found out? Lo and behold, they like those areas. Because it's different when you go there, and you know this, when you visit it for a weekend, or you visit it, or I do a 1-month rotation. Our students live in these communities. They go to church there, they buy groceries there, they go to football games on Friday night. They become part of the medical community. That's a whole different scenario. It's a lot harder to leave that. It's a lot easier to come back to that. And so we're starting to see the fruits of that labor right now. We have these communities that are signing contracts with our medical students while they're still in medical school to come back there and practice medicine. And so we see that as a game changer and as an innovative move to be able to help fill those workforce shortage needs.
So Dr. Frey and Dr. Speights, we talk about healthcare workforce is really a national problem. Now, this is not something unique to any region of Arkansas in particular. We see that nationally. So you mentioned some statistics that we can use to sort of lend to a person staying in Arkansas. But what can we do, like as a community? What do we need to be thinking about as a community to help attract and retain talent, in particular in some of those rural areas? So what makes Greenbrier attractive? I can tell you what makes Arkadelphia attractive. You and I can talk about that. We're both Arkadelphia boys. But what do we need to do in northeast Arkansas and this Delta region that we're sort of in charge of sort of populating here? What do we need to do to attract and retain them in our communities? Do you want to start, Lynd?
I mean, I'm looking to Shane and said he's actually had more experience in answering that question and that he has graduates who are doing that. Mm-hmm. One of the things we're going to do and we believe to be a competitive advantage for our new College of Veterinary Medicine, we will be recruiting students from those areas who come here to Arkansas State, who come to our College of Agriculture or to our colleges of math and sciences and mathematics. And those students then, as part of our training program, we were also following the distributive model. So I'm really proud that I'm following Shane. Basically, everything he said, we're going to be doing with veterinary medical students. Yeah. Instead of the last 2 years of training, the last year of their training will be back out in practices in these communities, rural Arkansas, where they go back home, basically.
What would you add?
So when we talk about retention, and that's really what you're saying, how do we train and retain this talent here? There's 3 different buckets you look at. You look at where you're recruiting, which you've heard Dr. Frey talk about, where you're recruiting them from. You're talking about once you get them into your program, what are you doing to expose them to the areas you'd like for them to stay? And then once they start to leave your program, how do you still kind of maintain that hold on them so that they're interested in coming back? And I want to actually this is going to sound strange, I want to go back to a comment that Senator Sullivan made. It was a question he had earlier about K-12 and about higher education. And that's where you start. You start in K-12 and you start having those conversations earlier. I do a thing every year. I do a lunch with the dean. Every one of our medical students, we break them out into groups of 10. It drives my assistant nuts. But we have lunch. And so I'll have it with 10 medical students throughout the entire semester until I go through all 120 of them. And I say, where are you from? Where did you go to where did you go to college? And why do you want to be a physician? 40 to 50% of those students, and I've been doing this for 8 years now, 40 to 50% of those students knew in high school they wanted to be a doctor. They knew they wanted to be in the medical field, they knew they wanted to be a physician, and they knew that in high school. But yet, as a medical school, I've largely sat back and done things with the pre-med group at the institutions, the colleges and universities. So we're moving further into K-12 to have those conversations. Because again, when we make data-driven decisions, the data says, if I get a kid from Arkadelphia to come to medical school in Arkansas and do residency in Arkansas, they are more likely to go back to Arkadelphia because they grew up there and they knew what it was like there, and I can raise a family here. It's nice to be able to get somebody not from that area and expose them there. That is successful. You're more successful if you can get them straight out of those areas of need. And I think that's a lot of work. I think on the K-12 side, we've got work to do.
Yeah, and I would build on that and say that Dr. Bancy, our Dean of the College of Veterinary Medicine, and I went to North Little Rock at the renaming of a grade school not too long ago for that very reason.
Well, Shane, tell us a little bit about this sort of pathway of freshman to physician. This sort of path that has been developed seems very different, and maybe you can put it in context to other states or other, but it seems very different. What is this sort of freshman to physician pathway, and how does that sort of help in this recruitment process for physicians?
So this is an exciting program that we've launched, and we're finalizing the pieces with A-State to get it on track here. We're so excited to be able to do this, and we call it a pathway program. And really, what we were finding, and I know you've heard through the last couple of sessions, you've heard conversations about the different generation of student. We're talking about Gen Z, Gen Alpha, and we're talking about these different generations of students, different ways they learn, and different ways they see the world. One of the things that we ran into is much of what Arkansas State has seen in other colleges and universities is that it's a little bit of a less prepared student. That doesn't work out well in medical school if you show up underprepared, because it's pretty much, actually it is, it's game on from day one, and there are expectations, and you have to deliver, and you have to deliver quickly. And so in recognizing that changing student, we decided to create a program where we would partner with specific institutions and start early on in college saying, look, this is what you're going to need to be successful in medical school. We've got the recipe. We know what it takes in terms of reading comprehension, in terms of being able to maintain a schedule, in terms of the specific core coursework that you need. There are classes that you don't need to take. There are classes you absolutely need to know and understand. We can give you that recipe. We can work with the biochemistry, the microbiology, the immunology lecturers and professors on the undergraduate level and say, look, you guys are doing a great job covering this, but we don't need this. So we don't need this piece here, we need more of this. This is where the students that we're getting from your institution seem to struggle. So it's a real close relationship between us as a medical school and a four-year institution to be able to get a prepared student that's ready right out of the gate to do medical school. And so we've got the partnership with Henderson State University. We've got it here with Arkansas State University. We've got 3 other institutions that have called us wanting this. We're trying not to bite off more than we can chew, but basically it's decided upon once they finish high school that they're going to go to medical school. And so if they're successful in their program on the undergraduate level, then we take them right into medical school. We'll do an interview, but for the most part, all of the MCAT, all of those pieces that as long as they maintain a certain grade point average at that institution. Now, what they can't do, you can't be that, hey, I'm going to take the tough course down the road at the easier place because this institution's harder. You can't do that. You've got to take all of the coursework at the partner institution. So, and there's some other rules that are in place. We're very excited about that. We're very excited about that for multiple reasons. The big one is the institutions we're partnering with, they recruit students from the areas we're trying to get physicians into. So you think about where Henderson State University is in terms of who their bodies. Think about Arkansas State University. Think about all of Northeast Arkansas and the students at the high schools in this region that come to Arkansas State University. We need more doctors in Wynn. We need more doctors in Walnut Ridge and in Pocahontas and in Piggott and in Perryville and all of these places, Batesville. And so we're seeing some of that trickle now, but we want to see that better. We want to see those physicians stay there. Before we get
Back to the hospital administrators, I want to make sure I fully understand the lingo, the distributive model, right? Mm-hmm. So that was your scenario of, hey, you're going to be in Greenbrier, you might be in Arkadelphia, right. You might be in DeQueen, you might be in Mena. Is there any sort of prioritization? Like, hey, there's a gap in Southeast Arkansas. Let's try to fill this there. And is there an intentional fill, or how do you get to this distributive model of who goes where?
We do. It's funny you bring that up. One of the first questions that I was received, I had a hospital administrator, it was actually Chris Barber, and he said, gosh, Shane, that sounds so neat. How do you get the students to want to go to those areas? We don't ask them. We say, we agreed to teach you medicine. We didn't say where we would teach you medicine. And so they come in, we let them know from the beginning, don't buy a house in Jonesboro, because you're probably going to be moving in your third year. So some of them don't, some of them stay here. Obviously, we still have students that rotate through both of our hospitals here and rotate up into Greene County and all over this region. Over in Mississippi County, we're actually expanding. We got some really neat things we're doing over there. But we do look, to your point, Mitch, about where the needs are. So yes, we've got a big cohort down in Camden and down in El Dorado, and I'm working on one in Monticello. We have to look, obviously, at the resources there. I can't send a student just to any place, because we have accreditation requirements they have to meet, because they have to prove competency. And so they're held to the same standard of a student who's at a major metropolitan area in terms of the exposure to different curricular pieces in the medical education. But yeah, we can meet most of those around a lot of the places in the state we send them.
And veterinary would sort of pursue a similar approach?
Yes, it will be a similar approach. We have over 200 clinical affiliates across the U.S., roughly half of those in Arkansas. And then we will take a model where we have hubs. So we have a hub in Northwest Arkansas, Jonesboro, Little Rock, Memphis, and in the St. Louis area. And then we will spoke out from that hub. And we have to do that based on the resources, based on the practices available to us.
That's what we do.
Okay, that's helpful. Thank you. So, Michael and Sam, just like private industry, and we talked about in the steel panel, there's this sort of rapid evolution of in the healthcare sector. And so I'm curious, what's your number one challenge? You know, what keeps you up at night? You know, what do you see in that sort of capacity that it provides sort of the most unique challenge in terms of need, and ultimately that affects workforce and quality of care and continuity of care? So what is evolving at such a pace that you all are trying to address? If you want to start there.
Sure. I think not going to be a surprise, and it fits the theme of our discussion today. I mean, it's really workforce and space for the demand that we see from patients in our region. We could invest a lot of money and build a lot more space to house patients in need, but we would struggle to continue to find the staff to really scale up in a meaningful way. And so workforce development in the short term and the long term is really key strategy internally and within our partnerships to continue to develop those resources.
So again, Michael, what do you see as sort of what's evolving at a pace that's a wee bit scary?
Yeah, I would agree with Sam on workforce. Another item that I would add to that is the change in healthcare itself. We talked about innovation. As an organization, we have to be very nimble. We have to be able to adapt and change very quickly. Right now, some of the technology that's coming out, we could buy probably 150 different AI platforms if we wanted to today, but the question is, what do they do for us? How beneficial are they? Do they help with the workflow with our team? I will say, as we look at workflow, we're going to have to, in the future, there's probably not going to be enough physicians and nurses. So how do we work smarter? So how do we bring that AI technology in to help to make the physician's work life better, or the same in nursing? You know, right now we're doing a pilot with virtual nursing in our facility, and it's really to reduce the workload burden with our nurses for admission and discharge, which is a key aspect of what they do on a daily basis, just to see what impact it has on the workflow. It will not reduce our nursing staff. It will just make it where they work smarter, they work better, and actually better quality of care and better patient experience as well.
Whether this is people or critters, I wonder where telemedicine fits in this journey for this idea of technology and workforce shortage and meeting people in a rural environment. Where does the space of telemedicine sort of fit into the modern day journey?
We've certainly seen a lot of attempts since the pandemic to really scale telemedicine quickly. We saw some of those work very well, some of those not work very well. I guess I would summarize it by saying if it's knowledge sharing or really mental health applications that make sense, it can work very well. But we have to remember in our industry, I think somebody used the word touch earlier today, it's still a high touch industry, right? It is a business, but it's high touch in a number of different ways. And telemedicine is not necessarily the best approach for that. I think in the future, maybe our population is more open to that. Maybe this next generation that grew up only knowing smartphones and video calls is a little more open to that. But for today, we really want to continue to focus on what can we do to scale the high-touch areas in our business, particularly in our region for our patients.
We can keep moving down there. Shane, if you have anything to add to that sort of approach, then we'll move right on down.
Yeah, to be blunt, I think we're missing the boat on telemedicine. I think we have different types of applications. I think it doesn't work when you've got a doctor in Jonesboro who, let's say, is an endocrinologist seeing a patient in Piggott, but they're now not seeing a patient in Jonesboro. I mean, you're just taking one patient for another. That doesn't make sense. Again, we've got a physician shortage in the state of Arkansas. So leveraging telemedicine might be that you've got a physician who's licensed in Arkansas but lives in Florida, seeing a patient in Piggott and then referring them to one of our systems here. That would be more efficient. We teach telemedicine in our medical school. We were actually the first in the country to do that. Stanford teaches it in the 3rd year, but we were the only one to start teaching it in the 1st year because we believe very strongly that that's part of healthcare and the delivery of healthcare. And our students need to be trained in that because the physician of the future will have to be able to utilize that at some level. I still don't think we've figured out exactly what the best model is, but it is absolutely a solution for many of our rural and underserved communities because you're never going to get an endocrinologist to move to Mississippi County. You're just not. The number of patients there that would dictate that kind of volume is just not there. There's an answer there. We just haven't really, I think, found the best solution right now.
Sort of to Sam's point. How does this fit with veterinary medicine?
Of course, we're very early in the development of our curriculum, so I can't really say we will not be teaching telemedicine today as it is, but that's somewhat dictated by the profession and our accrediting agencies. Now, do I see that opportunity in the future? Sure, I do. And there are certain aspects, for instance, our radiologist, you can read the film anywhere in the country, but as far as teaching, we're going to be teaching on site in person.
Yeah, again, high touch, and I get that. Michael, how does St. Bernard sort of process telemedicine's role in this journey?
We actually began telemedicine, really set it up with a robust program right at the beginning of COVID. We saw an opportunity where we needed to pivot really quickly, so we've been in a relationship and have had many aspects of telemedicine over the last numerous years. Where we see it, to Sam's point, it's a mixed bag. Where we see the greatest success is 80% of our behavioral health outpatient visits are done telemedicine. That's at St. Bernard's. 80% of our visits are all done telemedically. What we saw with that is, number one, our no-show rate decreased significantly because you're in the home, you're available. Another thing that our counselors also picked up on is you see the environment the individual is living in. So for behavioral health, that's extremely helpful. You see, are they wearing clothes? Did they take a shower? Do they look like they've eaten in 3 days? Because those are all trigger points from a behavioral health standpoint on needs that they may have. We saw such a great success with it that we applied for a federal grant that we were awarded in 2024, and we're just now launching that through HRSA. We now have a grant where we're going to put behavioral health via virtual telemedicine in all of our primary care clinics in 3 counties. So that's Cross County, Randolph County, and Lawrence County. We've already met with practitioners within those communities. If someone comes into a primary care facility in the rural region and that practitioner identifies they need a telemedicine visit, it can be set up immediately and can be done in that clinic while they're physically there. That's a game changer for rural communities because behavioral health is one of the greatest opportunities across the nation in disparity of care, especially in our rural counties within this region. So that is a very effective model with telemedicine that we're very anxious to see the results of that grant. And if we can model it and then replicate it in all 23 counties we serve, because the great benefit is you hire a counselor or a psychiatrist. They're here in Jonesboro, but they're seeing patients in 20 different communities on the same day, the same practitioner, because you do it via telemedicine. We also use it in other areas. We do, to Sam's point, we do a lot of support with our outlying ERs, with hospitalist program, with ER medicine via telemedicine, where it's been very helpful for our outlying practitioners in the smaller rural hospitals as well.
Yeah, and I think telemedicine is very important to us as educators because our students in the distributive model are going out of state. Mm-hmm. And both Dr. Speights and I have a relationship with St. Bernard's to provide the mental health counseling for out-of-state students.
I can see maybe certain areas that's more mature of a solution than others that sort of makes sense in that journey. Okay, this is for all of you. I think one thing that struck me when we were doing the last two panel discussions, in particular the Steele one, is we talked about the university's role in workforce development. I think 10 years ago, I think most universities would have recoiled at the idea that they weren't here other than to be liberal arts oriented, sort of a training of that. And that idea, and teaching people to think and to be lifelong learners and to be well-rounded. I'm a product of a liberal arts education. I value that. But it's interesting to see how East State has really sort of developed this complementary pivot that is also very workforce development focused in terms of helping our industries be successful and in turn helping our community be successful. So I think when I was growing up, there was just not this sort of common language of workforce development and liberal arts sort of living together. So with that in mind, this collaboration that we see in so many university efforts where the university is actively involved in building better community health, but also workforce development training to feed these partner institutions. I'm curious, what needs to happen at the university level to strengthen those partnerships and better address community health and workforce needs? Like you can wave a magic wand that says, hey, we could use this out of the university level, or is there something that we can sort of think about and look to the future to aspire to that the university system can be even a better partner for what your needs are in workforce development in the next 5 to 15 years? You want to start, Michael?
I'd first start by saying we have had a tremendous relationship with Arkansas State, have for many, many years, and we're a clinical site for all of the programs at Arkansas State related to healthcare. In fact, just to give you a glimpse, on an annual basis, we have almost 700 students that rotate through our facility from all the different specialties from undergraduate to graduate. So the relationship has been phenomenal. I think what we would need to look at moving forward that would be most beneficial, we've already touched on, and once again, Senator Sullivan asked this question, how can we, Arkansas State and St. Bernard's, collaborate to go down to the K through 12 to really encourage our young people to find an interest in healthcare? Sadly, during the pandemic, there was a little bit of turnoff with healthcare nationally, and you actually saw a lot of burnout with physicians as well. And so you have this group of physicians that have children, that those children don't necessarily want to be physicians because they saw their parents during COVID. How do you revitalize that desire? Because it is a great career to serve people. It is a great career to serve the community, to make a difference. If you want to see something where you can go in and make a change that day, healthcare is that field. But how do we collaborate and come together and create that revitalization in the interest in healthcare at the K through 12, moving on then, of course, into, it will then determine who goes into college level for education and on to such medical school.
Yeah, that's interesting. Dr. Frey?
Well, I think Chancellor Schill spoke to this a bit earlier today, and then the last panel when we talk about culture. I would say that under Todd, the culture at Arkansas State is changing, and the change is that we have to change what we're doing. We can no longer act like we did 10 years ago, 20 years ago, or 30 years ago if we want to be in business 10 years from now. And so that starts at the top, this change mindset.
Yeah, great point. Shane?
Obviously, we have a very intimate relationship with Arkansas State University that just continues to grow, and we just continue to find more and more opportunities to be able to serve the communities of this region. The Pathway program, obviously one great example of that. What I think, one of the challenges is, which I see A-State addressing it more than any other institution. I think about my own kids. I've 25, 22, 17, and 14, so a broad range there, and they've all got the answers. You can just ask them. But at any rate, I've got several of them who they just want to go to college just to get a job. I'm going to college just to get a job. And to your point earlier, Mitch, there's so much more that happens in that college experience that's not being discussed, not being talked about. Conflict resolution. I don't like the roommate that I've got. I don't know that I feel comfortable talking in front of people. I think A-State does a better job of not only producing that component needed in workforce, but that component needed in the community. And really, I think that's a larger task for higher education, is not only to educate a future workforce, but to educate future leaders and future community members who are going to give back, who are going to be involved, who are going to be on a stage like this, who are going to help plant those seeds for trees they may never find the shade under. To be able to look forward at other generations, not just for themselves. A lot of that comes out of experiences and education that occurs, we call it the hidden curriculum sometimes. We do a lot of that in medical school. We try to raise them up in different ways. It's not something that you can point to in a syllabus, but there's education that occurs just the same. And I would challenge higher education to continue looking for that, because I don't think that's talked about a lot. I do see that more through Todd's leadership. I do see that more through the changes at Arkansas State University, and I'm excited about that. One of the most, just a quick story, one of the most popular freshman courses at UCA is adulting. That's a filled class. The most popular freshman course at UCA is adulting. Students want that. They want that information. They want, and I think it's already been discussed a couple of times. They're eager to learn. They recognize they have blind spots. And so I feel good about the direction A-State is going in, the partnership that we have, and the future endeavors that we've got planned.
Yeah, good context. So Sam, if you could advise A-State or any other university, like what do we need to be thinking about to sort of meet the workforce needs for you and others in healthcare?
Like others have mentioned, we've had a great relationship with Dr. Scott Gordon, the Dean of the College of Nursing and Health Professions, and his team, and certainly appreciate all the work they do and the conversations that we have about how do we make improvements on the experience for the students that are coming out of the Arkansas State University programs, not just for the sake of bringing them in and helping make them good clinicians right off the bat, but also able to contribute to the improvement of healthcare, the improvement of the work that we do as fresh faces and fresh minds coming into the industry, and bringing that perspective that they've learned, good or bad, from before their career started, whether that was as a high school student during the pandemic, kind of hearing all the things about healthcare through that experience that may have scared some away or even raised new questions in their mind, and how can we learn from that and let them come in and be part of the solutions that maybe we haven't seen, those of us that have been in the industry for some time. And then also just thinking about going upstream into K-12, we see a lot of teachers in our community that are surprised that, hey, we have jobs aside from just nurses and doctors in our building. I know it's surprising, but we see a lot of students that say, hey, some of the folks that have been on the stage today have said, this generation wants meaningful, purposeful work. They may not want to be a clinician. That's great. I'm not either, right? But you go and find that purpose in healthcare and contribute in a number of different ways. That's certainly a major possibility still in our region.
All makes great sense. I think we heard in the first panel, and I think anybody who's in professional economic development will tell you, quality healthcare drives economic development. But I hope you see that these folks are kind of, as major employers, are actively part of our community in that respect, but obviously contributing to the overall health of our community is such an incredible and noble, important mission. We appreciate what you do, and thank you for serving today. We are going to try to keep moving along for weather-related things, just to make sure everybody feels safe when they do depart here later today. So we're going to break here at 3:30 for a 5-minute break. and then come right back and get our last panel going. And we talked about mental health and sort of its sort of role in nature and importance, and I think there's a big topic coming we'll want to be a part of. So we'll take a 5-minute break, and we'll be gathering right after this. So thank you very much. We appreciate it.